loves writing, she loves coffee, jollof rice and traveling, not necessarily in that order. So absolutely delighted to introduce Izzy to you today and hand over for the presentation.
Thank you very much, Andrea. Thank you again for inviting me to this space. I'm really, really looking forward to this talk, but also the, I guess, dialogue that this talk hopefully stimulates. And I like a key thing, you made reference about how you have to go back to the video. I'm very similar as well in that I think when it comes to this space, there's just constant learning to be done. So you're certainly not alone in that space. So many of you on the call would either have heard of the video or watched the video. And certainly if you haven't watched the video, I do encourage you to go back and watch it, not because I made it, because I think in preparing that animation, the main reason I prepared the animation is not because I'm an animator, it's because I wanted to challenge myself to be able to have these discussions in an easier way in the various environments I find myself. So many of us read, but sometimes the literature and the reading is hard to communicate to people in a short time scale. And in my capacity, obviously, I'm a clinician. So I'm often speaking to people on the front line who have not even had their tea break. So kind of reading them the riot act about the ins and outs of race and racism is not always appropriate when you're on labor ward. So I'm always thinking, how can I have these conversations? So that's what led to me trying to be a fake animator. So the slides will be available to you and the recording will be available to you. My only ask is you may use the slides as you wish, but please do credit me if you use the slides. Please do include the relevant references of the people who have done the research in the slides, and also please only use it for educational and non-commercial purposes. So I have a conflict of interest, and it's not that I am currently being funded by some like drug pharma for good or bad. It is that my conflict of interest is the reason why I'm sat here in front of you on a Wednesday morning. And this is really my positionality. So it is the perspective from which I live and operate in my clinical, in my slightly academic, and in my advocacy work. Um, if you're looking at me and you don't have any visual disabilities, you will see a Black woman. You may or may not know that I am a Black African woman. I am from Nigeria. And in some rooms, I'm an immigrant. Other rooms, I'm an expat. It depends on who you're talking to or who I'm talking to, I guess. My native language is Igbo, but I am very fluent in English, less fluent in Scot. And obviously, I've been educated to a high degree, and I am a clinician, and specifically an obstetrician and gynecologist. And a lot of the advocacy and research I'm interested in is reducing disparities for racially minoritized people. So I simultaneously, I guess, occupy the role of people who have been oppressed and at the receiving end of, I guess, reproductive injustice, but I'm also part of the group who historically have been perpetrators of that. So it's a very interesting place to be in, and it's something I consider, or I try to reflect on whatever I'm doing, and it often causes a bit of conflict, because in some settings, so for example, in my community engagement work, some settings, my insider status is helpful. Other times, my outsider status is really unhelpful. And I have to be mindful of that. And I'm grateful that I'm surrounded by groups of people, my friends and my family, who keep me accountable. And I think this is a very important thing when we talk about this subject matter. And in particular, when we're thinking about any minoritized groups, to think about one's positionality in the work. So today we have only one learning objective. You'll be happy to know it. It's a chunky subject, one learning objective, and I'd like to move all of us from race-based medicine to race-conscious medicine. Okay, and the way we're going to do that in terms of the outline is three things. I'm going to try and provide a useful background on race, races, and racism. I won't go too much into depth in that because I'm making the assumption that many of us on the call have done the work already, and also we've included a lot of resources that you can read in your free time. So we're going to provide a background on race, racism, and risk. And then I'm going to provide what I believe is a useful framework for an anti-racist risk assessment. And then collectively, I'd like us to apply this framework to different clinical scenarios. So I hope you have your coffee because we're going to be getting people to get involved. So kicking off, I'd like you, if you can, to participate in this poll everywhere poll with me. So you can do this either by using your phone and scanning this QR code at the top, or you can go to the website pollev.com/ IOKOLO035. And I'd basically like you to respond. So the response is anonymous, by the way, so we won't know who's typed in the response. What kind of examples of race and ethnicity have you seen being applied in medicine and social care? So you can think very broadly. I'll start one. I've seen the narrative that Black women have differently shaped pelvises, and so that might impact, for example, how they may give birth. That's one I've seen. What else have you seen, or have you heard of, or have you read of, or have you been told? So we're not saying what do you believe or not believe. If you believe or not believe it, that's neither here nor there. I just want us to collectively generate some examples and just let me know to make sure that we can. Oh, great. So we got one response, so it's working. Because I mean, if you get through a meeting nowadays, an IT glitch, it's a miracle. There we go. So we've got different pain thresholds. We have also Black people have different pain thresholds, collecting blood, pain thresholds. We've got pain coming through quite a lot. Black people have thicker skin. Okay. What else is coming through? And we heard about the pelvises. Black women would only have fibroids, not endometriosis. Yep, yeah, I've definitely heard that. Race as a risk factor for type 2 diabetes. Again, pain coming through. Black people have higher pain thresholds, low uptake of vaccines. Really good thing to think about. That Black people have different pain and lung capacity. Something about kidney function. Yeah, absolutely. I think it's the EGFR, isn't it? And we'll talk about that. Risk blood donors. Yeah, they're all very useful. A wider hips so babies can turn around later in pregnancy. Okay, keep them coming. We'll just do it for another 30 seconds and see if there's anything else coming through. Yes. And all of this will also be available to us at the end. I'll try and summarize it and include in the final slide as well. Low uptake of vaccines, higher pain thresholds. Yeah. So I think that's about it for now. Yeah, thank you so much for, oh yes, quite shocking stats about maternity care and stillbirth. Bone density, yes. More likely to have sickle cell anemia. And then what else? More likely assumptions on sexual act. Oh, you guys are getting, it seems like you guys just had another coffee. Okay, wow. Okay, darker iris need different drugs. Okay, so that's like an ophthalmological context. Assumptions on sexual activity and reproduction, more likely to genetic, physiological, socioeconomic, lifestyle factors related to type 2 diabetes. So we've seen type 2 diabetes come up twice now, all very useful, and different BMI. Less likely to be a blood donor. Great. Thank you so much for participating with that. That was very useful. So a couple years ago, I asked a room full of surgeons at Harvard the same question. And because, I like to think I'm a non-siloed thinker. I like to go into spaces where there are people not like me to challenge myself. And so this was a great opportunity because normally my day-to-day life is all about women. So to have this opportunity to speak to a room full of surgeons, these are the kinds of things they said. Many of them resonate with what we've already shared already. So they gave examples, for example, in maxillofacial surgery, how people thought Black people had harder bones. When it comes to anesthesia, this myth that African American pain tolerance was higher. When it came to dermatology, this again assumption that Black people could tolerate pain. Renal medicine, somebody put a comment about something about renal medicine. Yes, so up until I think 2022 in the UK, we had what was called a race correction for what's called the EGFR, the estimated glomerular filtration rate. Now, I am not a renal physician, but I do use EGFRs. It's a way of quantifying somebody's renal function, essentially. And historically, there was a race correction included in this in the UK up until 2022. And in some parts of the States, this is still being used. Hispanic women have a lower pain threshold. White women are hysterical. Asian women have lower pain threshold. Black women don't get prolapses. Refugee receive worse health care. Orthopedics, police officers saying hospitals should shackle AA. Okay, yeah. So some of them are pretty traumatic to read. But I guess what is actually really useful to acknowledge is that these narratives are everywhere. Okay, they're everywhere. And many of these narratives, until you ask people to think about them and give examples, are operating on a, I guess, subconscious level. And this is really important with regards to the practices and, I guess, evidence we use in managing people. So I'm assuming three key things in this talk. One, that that race is not the same thing as ethnicity and is not the same thing as social class. What they potentially have in common is that they are all social and power constructs, and they can determine access to things like health and social care. We know that race is a term that was essentially created essentially for the subjugation of non-white bodies. And this artificially created racial hierarchy placed white bodies at the top, black bodies at the bottom, and essentially predetermined historically, but still has an enduring legacy with regards to who gets access to power and in what context. Ethnicity depends on who you speak to. So I was speaking to one of my friends, who's I think on the call just now, Dr. Gwyneth Curry, about how ethnicity looks like and is defined in the USA is actually a bit different from how it is looks like and defined in the United Kingdom and across Europe. So perhaps in the UK setting, we are thinking of ethnicity more as a combination of potentially ancestry, culture, language, diet, religion, and there are some overlaps with physical traits. But whilst in the US, so for example, in the US Census, when you're filling out the census, there would be a segment for race and ethnicity. And when it comes to ethnicity, they would often categorize it as non-white Hispanic, or I think, yeah, non-white Hispanic, or so non-Hispanic or Hispanic essentially is the way they tend to categorize it. I don't know enough about the US setting. Maybe Dr. Curry can tell us a bit more about it at the end. But I guess it's just useful. I guess what this my discourse illustrates is whenever you are talking about race and certainly ethnicity, it's important you know what you're referring to. So often in the UK context, it's clear what we're referring to, but if you're in a different context, it's important to clarify. And then, of course, it's very different from social class, which again depends on who you're speaking to. This may relate to, for example, where somebody lives. It may relate to their educational attainment. It may relate to their work, for example. So very important that we do not conflate these three terms. And I'm assuming that you know that racism exists, and it exists in various manifestations, be it the systemic manifestation, institutional racism, the interpersonal, which is often what people think about, the one-on-one microaggressions, racial slurs, and things like that. And then the one that's often not spoken about as much, which is the internalized racism, which is where individuals from racially minoritized groups essentially accept the negative stereotypes and narratives around their existence. And this can lead to problematic things such as helplessness. It can lead to withdrawal. It can also lead to the phenomenon where you see racially minoritized individuals actually being perpetrators of racism. But when we think of the systemic forms of racism, we're thinking about how this manifests due to historical and enduring barriers and structures, such as, for example, access to housing, education, access to financial means that can help progress you, what it means with regards to protection from environmental toxins, what it means with regards to your nutritional status, and also opportunities at work. And then the structural determinants of health, a term that I'm sure many of us have heard of, essentially the conditions in which you are born, live, grow up, and die. And essentially, the most important aspect of your life because they are a big cause or driver of either good health or poor health. And what I want us to take away from today is that racism is a structural determinant of health because it will impact where you were born. It will impact how you grow up, how you're educated, how you work, how you receive care, and also, extended things like how you are treated, for example, in the criminal justice system, and also ultimately how you die. So, in terms of the Human Genome Project, we know, and we've known for many years now, that race has no biological foundation. And yet we continue to see examples and narratives and risk assessment that tends to center this fake biological narrative. We actually have evidence that human beings, we share almost all of our DNA in terms of the similarities. There's actually more genetic similarity between so-called racial categories and actually higher bits of diversity within individual categories. So this is really important to acknowledge, especially when people try and use the biological argument. So, in terms of the biological argument, often there's this kind of concept of these five very distinct racial categories, where there is no overlap and where what distinguishes them is essentially this biology. But actually, when you look at the genetic variation, what you see is that the overlap is actually, there's actually more overlap and more blurring of the lines between so-called racial categories. And this was especially proven by this 2022 study by a group of scientists in Stanford, where they tried to essentially look at the genetic diversity across regions of the world. So you can think of alleles like a flavor of a gene. So we all have, for example, the same gene for hair, but many will have different flavors of hair, which are alleles, which might mean I have like dark and really curly hair, whilst Andrea will have, has straighter brown hair. And so we have different alleles, but the same gene. And what this study found essentially is that of all human alleles at that point that we knew existed, 92% of them could be found in pretty much half of the 7 geographical regions of the world. And half of all human alleles are found in all geographical regions. Again, this idea of biological uniqueness is not true and really not the foundation for race. Race is a construct of power and societal norms with regards to who counts and who does not. So that's a quick way to debunk any myths or any pushback when people are trying to use race in that context. I love this picture because I totally agree with it. We are all immigrants. Some of us have just been here longer than others, okay? Another thing, I think, another argument against people who try to push the kind of biological essentialist view of race is this description of the healthy migrant effect, which many of you may have heard of. The healthy migrant effect essentially explains the phenomenon where migrants are actually, on average, healthier than the baseline population whenever they first migrate to that country. And this a higher level of health usually lasts for about 10 to 15 years. Thereafter, you see examples about how the migrants' health kind of either go to the baseline of the population or in some cases drop below the baseline population health. And this is again very important when people, for example, think about race. When you have, for example, if you're looking after a Black man, for example, who may have been born in Scotland, and also looking after a Black man who may have been born in Uganda. Again, two very different backgrounds, both Black men, and very different experiences of health with regards to where they were born, how they grew up, how they were educated. Can you really justify treating those two people in the same way because of the melanin in their skin? I think no. What's really important to, I guess, acknowledge in the healthy migrant effect is that it's possible. The rationale behind it, I guess, is potentially the people who are migrating tend to be have higher educational or socioeconomic status and potentially just healthier behaviors compared to people who would stay in the country. There's some of the rationales. And in Scotland, especially, we have the Shell study, which again demonstrated and described impacts of the healthy migrant effect, whether it was with cardiovascular disease or even in my specialty, obstetrics and gynecology. So we see examples of this from all over the world. Does anybody know who this man is? Other than a very happy looking old man.
Desmond
Anybody
Tutu.
know? Yes, it's Desmond Tutu. So many of us will know the late Desmond Tutu as a very important religious figure, but also a figure globally when it came to social justice and certainly the anti-apartheid movement in South Africa. But many of you will not know that he's also my birthday mate. And he is credited for this very important quote, which is that we need to really stop thinking about pulling people out of the river and thinking about stopping them from falling into the river in the first place. And I think this is a good foundation when it comes to thinking about race and risk assessment. Okay. So in terms of thinking about the river and upstream factors, this will be the most difficult slide of the day. Once we get through this, it will be much easier, I promise. So um, if you are an epidemiologist in the room, or if you have done any kind of epidemiological studies, you may have come across DAGs, or directed, I can never pronounce it, acyclic graphs, especially when it comes to the subject matter of causal inference. And it's essentially a visual way of trying to understand how exposure to one variable may lead to whatever outcome. And many of us, if you've come across from any studies, may have heard of terms such as confounding factors or effect modifier factors. And often race is treated as a confounding factor. The difference between the two essentially is a confounder is something that has an impact on the exposure and the outcome you're looking at, but it doesn't really have an impact with regards to, it's not involved in the causal pathway per se. So a confounder may be thought of as a bit of noise in the background that is distracting you from understanding the relationship between the exposure and outcome. So one way to minimize that noise is to adjust for confounding factors. This might be a phrase people may have heard of. So an example might be, for example, if you're looking at a study between, I don't know, like coffee drinking and lung cancer, if that's what you wanted to study. So smoking in that scenario would be a confounder because, of course, smoking doesn't, we know in the causal pathway, it's not the smoking that causes people who drink coffee to get lung cancer. But we know that smoking, there is evidence that smoking, of course, increases your risk of lung cancer. So it's a confounder related to the outcome, but also studies that show that there is a correlation between smoking and higher levels of coffee drinking. So that's an example of a confounder. An effect modifier is different in that it is related to the outcome. And sometimes may have an impact on the, I guess, causal pathway. So, for example, let's say you were looking at a relationship between a new drug, let's call it drug X, and its outcome. Let's say you found that drug X, one of the outcomes it had was lower levels of blood pressure. And in your study population, you noticed that actually the impact of this drug was different for men and women. In that case, gender, as an example, might be an effect modifier. And a way to, I guess, understand that a bit more would be to stratify the two groups and study in detail how that effect is different with those two groups. So in a way, an effect modifier kind of explains a bit more the relationship between exposure and outcome as opposed to causing noise. So a lot of technical stuff. The reason it is important to think about that is, you know, think about, for example, we know the statistic that Black women in the UK are currently 3.7, so 4 times more likely to die in pregnancy and childbirth than their white counterparts. And I think Asian women, I think the statistic is just shy of 2 point something more times likely to die. When you hear a statistic like that, what we tend to focus on is, again, the Blackness or the Asian descent. What that statistic, especially in research studies, often do not I guess, further explain as the context in terms of the conditions that either make it more likely to die or less likely to die. And this is very important because unfortunately, we then take the, I guess, headline from studies and add them to our guidelines, our policy, and they feature on the media such that the assumption about the cause of death is the Blackness or the Asian descent, as opposed to the environmental factors. If you were actually wanting to understand the causal pathway that leads to differential outcomes when it comes to race and ethnicity, you would really need to do a much deeper dive into these upstream factors. And what would these upstream factors potentially look like? So some of these are presented in this study by Howie et al., where they essentially pin out 10 solid recommendations on how to use causal diagrams to understand racial health disparities. So, an example of a much better causal analysis when it comes to race would be this. Now, this is quite messy and complex. And the reason I think we potentially don't take the time to do research of this caliber is because the knowledge around how to one, understand, two, measure some of these upstream factors is limited. And this is also a reflection of who is involved in research. So often you have homogenous research groups, and I'm thinking about my specialty, for example, in medicine. We are dealing with upstream factors that relate to historical things, social things. And so to have a group of researchers looking into maternal health disparities, and you don't have somebody with a social kind of sociology background, or somebody with historical background, somebody with anthropological background, I think is means that your research is ultimately flawed. And I guess as people advocating for disparities or against disparities, one of the things we need to do is put pressure on the people who fund research, because if they set the terms and minimum requirements for these teams to be, I guess, professionally diverse in their backgrounds, this may lead to better research. But what you can see, for example, here, outcome COVID-19 hospitalization. So along the pathway in terms of adverse outcomes for hospitalization, yes, you have here membership to marginalized or privileged racial group, but you also have here along the pathway the impacts of internalized racism, the impact of institutional racism, such as policies which impact people's access to minimum wage, discrimination that people may experience when they are in certain environments, hospital policies and racist policies, for example, EGFR, and adverse contexts or circumstances, such as multiple house living or living in environmental areas where there's high levels of environmental toxins, or living in places that are heavily policed. All of these will have a knock-on effect when it comes to outcomes. So I guess the tagline for this is if you are studying or exploring disparities, you really need to put in the work. And the reason you have to put in the work is because if you do not, you will contribute, despite your good intentions, towards biological essentialism. This belief that non-white bodies are broken and different and damaged. So the pathologizing of Black and brown bodies and ideologies is so easy to do and done day in, day out with our research policies and guidelines that have good intentions. And this is why myself and a group of my fellow authors wrote to the BJOG when this very important publication came out in the UK in 2022. And essentially, this was a study which was looking at reducing the rates of placental dysfunction, things like raised blood pressure, and mortality around the time of birth in racially minoritized groups. And essentially, the biggest flaw of the study is that, like many studies around race and ethnicity, the conclusion implied that the problem was with Black and brown bodies, and it did nothing to essentially critique the environment around systemic racism and institutional racism. And the problem with this then is people like me and good people who are nurses and midwives and policymakers then make policies and guidelines and introduce interventions based on these recommendations that don't address the source of the problem. So a very good resource to look at if you want to advance, I guess, your dialogue and communication about how racism is an upstream factor is really the Lancet series on racism, xenophobia, and discrimination. And essentially what it explores is the different ways in, I guess, racism can impact adverse health. Three key ways with regards to behavior, psychology, and physiology. So yes, racism can have a biological impact on you. With regards to behavior, this is with regards to, for example, how the experience of any form of adversity or racism institutionally may impact how people engage with healthcare. It may explain compliance or non-compliance. It may explain the mistrust and potentially going for non-recommended medical options. It also impacts the psychology with regards to the cognitive burden and the emotional burden of finding yourself in a space where you are potentially at harm. And even when the harm isn't there, it causes a hypervigilance that can have a knock-on negative impact on your mental well-being. And in terms of the physiology, we have evidence of a phenomenon called weathering, biological weathering, where chronic exposure to adversity, such as interpersonal, systemic institutional racism, over time can actually cause a shortening of your telomeres, the ends of the DNA. And over time can cause this buildup of allostatic load that can over time manifest in adverse metabolic health, and unfortunately, this effect can be transmitted across generations. This is what we would call or term an epigenetic effect. Now, the key thing and the key distinction between epigenetic effects and this wrong narrative around biological essentialism is epigenetic effects can be prevented and reversed. Biological essentialism takes a wrong standpoint, which is essentially a fatalistic standpoint and puts the blame and the negativity on the Black and brown body, whilst epigenetic effects actually explain and showcase the impact of the environment. So that is a key difference. So next question. Let's talk about risk, right? When I say the word risk, what word comes to mind? Any word, anything. There's no right or wrong in this space. Everything is valid. So when I say the word risk, danger, absolutely. So danger is a very common one, dangerous. I love these word clouds because so as the words come in, we see them moving. And then when there are multiple words, if there's a particularly common word, it gets bigger. So we can see where we are thinking collectively as a group live. Choice, bad choices, statistics, worry, negative, harm. Yeah, and danger, as we can see right there in the middle, bold and bigger than the rest. Mitigation, we want to mitigate risk. We don't like risk. It's bad. There's a fear of risk. There's a balance, we need to balance out the risks. Limits choices. Yeah, so these are all very, very useful. Yeah, so this is exactly what we think when we think of risk. And the key thing is nobody, well, I would say most people would like to avoid risk. Nobody wants risk. And certainly in my specialty, we do everything to minimize risk for the mothers, the pregnant people, and the babies we're looking after. And this is valid because risk can cause harm. But the problem then is, what is the negative impact of using race as a risk factor? First of all, I thought I should make a balanced argument, right? Because there must be some benefits of including race as a risk factor. Some of the ones I could think of, and I'd love to hear from other people as well, is if you included race as risk factor, potentially it could mean that certain groups would get additional resources. This may look like additional support, for example, continuity of care. It could be additional resources with regards to additional financial resources, which arguably might be beneficial. It could improve access, for example, by lowering barriers. If it means that there's been challenges in accessing care, maybe if the barriers are lowered, then certain groups of people can access care quicker. Certain groups may feel valued, and this might be useful in the context of where historically these groups have been mistrustful and distrustful of the system. So I think you could argue that there are some benefits of using race as a risk factor. But then what are the cons? Think back to the words that we have just used. So consciously or subconsciously, if you are perceived as a risky person, it ultimately causes stigma of the group. And this stigma is implicit or complicit. Is complicit the opposite? Yeah, I think it is. And the problem with stigma is it further solidifies already existing biases. And we have solid evidence that one of the negative impacts is it can increase medicalization, unnecessary, unwarranted, sometimes not necessarily evidence-based care that ultimately can then lead to what we call iatrogenic harm, harm caused by us, essentially. Another thing to think about, thinking about our principles of medical ethics. Yes, first, we want to do no harm. We want to minimize risk, but then we want to do good and we want to maintain autonomy. But what about justice? What about the rest of society? I will present in a couple of slides evidence of how racial risk assessment can actually lead to a waste of resources and misallocation of resources for other people in society. And then the last con I could think of, and there's probably more, so I welcome you to contribute to this as well, is it is very difficult to suspend disbelief. Once you have made the suggestion that this person and this body is risky, it's very hard to reverse people's beliefs. And I will illustrate how this can show up in healthcare systems. Now, this is a busy slide, but this is what I think, based on my reading of other people's brilliant literature, are steps we can take to be anti-racist in our framework to reducing risk. I think we have to ask ourselves a couple questions. Have you, first of all, explained or defined race and ethnicity? This is important because maybe in the States it's different, here it's different. So what are we talking about? Are we actually all talking about the same thing? Whatever intervention you're introducing, is it based on robust evidence? Have you actually identified the factors in this causal pathway between the exposure and the outcome, thinking of those upstream factors? And is there a possible causal mechanism in this pathway that could justify the race correction? Have you named and acknowledged racism in all its guises as an upstream risk factor and as a determinant of health? And have you sufficiently educated the people who are going to use this intervention to hopefully cause less harm about racism, systemic racism, structural determinants of health? Have you conducted an equity impact risk assessment? So thinking about how it will impact that group, but also the wider society. And have you demonstrated that the impacts are more beneficial than harmful? Now, if you haven't even asked yourself these questions, you need to be asking yourself, like my grandmother would say, what are you doing? Okay. Remember, intention is not good enough. And I will illustrate shortly how good intention can get us in very dangerous places. So in 2021, following the COVID-19 pandemic and following the death of George Floyd and the rise of the Black Lives Matter movement, there was a spotlight shone on racially minoritized health disparities. And one of the things that people were, I feel, desperate to do was to do something good. This led to the consideration of NICE, many of you will know, as a leading body that provides evidence base for how clinicians practice, to release a draft document recommending that all racially and ethnic minoritized women and pregnant people, regardless of their general health and the well-being of their babies, regardless of whether they'd had uncomplicated pregnancies so far, should be induced at 39 weeks. Now, I cannot make the assumption everybody in the room is obviously has either had a baby or knows much about the obstetric maternity care system. On average, a term pregnancy, well, officially it's 37 weeks, but 40 weeks is what we would say. An induction of labor is a medical intervention where we artificially bring on labor, and it's usually recommended because we think on balance, the benefits are higher than the risks. The commonest reason we induce labors in the UK is because women have gone past their due date. which will vary depending where you are in Scotland, for example. So let's do the equity risk. Let's apply our anti-racist framework to this recommendation. Did they explicitly define race and ethnicity? They did not. Was this intervention evidence-based? There is evidence that induction of labor in high-risk communities will improve outcomes, but there was no evidence that this would work for racially minoritized and minoritized ethnicity people. And yet the guideline draft went out. Did they identify any factors in the causal pathway? No, they did not. Did they think that race was in the causal pathway? I said no, but actually they did, which is why I think it went forward. Did they name and acknowledge systemic racism as a structural determinant of health? They did not. Did they take time to sufficiently educate the people who would be using this guidance around racism? They did not. Did they conduct an equity impact assessment? They did not. And did they have any evidence that the impact would be more beneficial than harmful? They did not. And yet this guideline went out. And unfortunately, this is a really good example of how suspending disbelief is tough. So this guideline went out in 2021. It caused a massive uproar. People wrote to the NICE. There were publications of doctors and midwives and patient groups and service users that this was crazy. And thankfully, it was dumped in the archives, never to be seen again. However, the impact is still being seen all over the UK in various labor wards. We have evidence today that racially minoritized pregnant women continue to experience higher levels of induction of labor and medicalization. We have evidence in some units that people are induced purely because they don't speak English or because they are perceived to have received antenatal care outside the UK. I have anecdotal evidence about how practice varies because of
She has frozen for me as well. For a while, I also thought it was just me. We'll just have a pause. I'm sure Izzy will come back in a moment. And while we give some time, is everybody
I'm
able to hear
very
me?
sorry. I'm not sure what happened there. I just got disconnected. Sorry about that.
So glad you're back.
Yes, sorry. Can I just double check? So I recall being disconnected at the slide showcasing where basically how suspending disbelief is tough. Is that right? Okay, just want to make sure on the same slide. I'm really sorry about that. That's very strange, but that's okay. Like I said, no meeting is complete without some IT glitches. Right. So on the right-hand side of the page there, what you will see is QR codes where you can essentially scan to look up evidence of how, unfortunately, suspending disbelief is tough. I recommend that you read the AMA birthing report, which essentially is looking at outcomes for predominantly migrant women in Glasgow region. And also very recently, the Scottish Patient Safety program hosted a webinar looking at racialized perinatal inequalities. And I spoke alongside a brilliant midwife, Nicola O'Brien, who's a very senior midwife doing work in Glasgow. And she presented findings, evidence of here in Scotland about how racially minoritized patients, unfortunately, are inappropriately risk assessed and subsequently have inappropriate medical interventions. And this is taken from a open access slide with Nicola had gave her consent to be available online. But I want to acknowledge that this slide was prepared and presented by Nicola O'Brien, and I've used it with her permission because it's online on the website and actually people can access it as well. And essentially what she found looking at data essentially is that despite the fact that when you actually properly risk assess minoritized ethnicities, they were not higher risk than the average white British. She found evidence of using CTGs, which are a way of detecting the baby's heartbeat electronically without indications. She found evidence of the use of something called a fetal scalp electrode, which is something we place on babies' heads to detect their heart rates a bit more accurately, again, without any indication. She found evidence of higher rates of, slightly higher rates of unplanned cesarean births, and also higher rates of non-medically indicated episiotomies, which is a cut to the perineum when you are in labor. So again, suspending disbelief is very hard. This is an example from the States, specifically from the Texas Health and Human Services Department. They sought to reduce postpartum hemorrhage, which is globally the leading cause of maternal deaths. And they did a deep dive into their population and they looked at the pathways that led to postpartum hemorrhage in their cohort of women. And they found that the cohort of women most impacted were non-Hispanic Black pregnant women. And they essentially didn't just look at the disparities with this group and other groups. They looked at how, for example, differences in recognition of postpartum hemorrhage may impact the outcome. They looked at how differences in responding to the, recognition would impact the outcome. They also looked at differences in escalation of care and also differences in timeliness of transfer to things such as theater. And they found that yes, non-Hispanic Black women had higher rates of PPH, but also the detection of PPH was slower in this group. They found that the escalation to receive drugs that we call uterotonics, which are drugs that squeeze on the uterus and reduce PPH, were slower. So these group of women were less likely to get a uterotonic in a timely manner. This group of women were less likely to be escalated to medical care if required. And also this group of women were also less likely to be transferred to theater for surgical management of their PPH in a timely manner. So they concluded that whilst there were disparities in this group compared to others, the disparities were triggered or caused by institutional racism, by their staff not being able to detect conditions in darker skin, by their staff having underlying racist biases against this group of people. And whilst they sought to actively reverse that with regards to education and awareness and prioritizing it in part of their quality improvement effects, they decided at that point, this group of women were at risk of being harmed by the system. And this is why they justified having non-Hispanic Black as a tick in the risk assessment. So very different pathway, very different way of thinking. In this intervention, they clearly defined race and ethnicity. In this intervention, they showed that risk assessment that acknowledged systemic and institutional racism did improve outcomes. They also were able to evidence institutional racism and interpersonal racism as a causal factor in this group. They didn't think They thought because it was part of the causal pathway was why they would justify, and because they couldn't respond quick enough to it to protect the women, they justified leaving it in. They named and acknowledged racism all over their risk assessment. And they did everything they could and are continuing to do so with regards to raising awareness. And they did conduct an equity impact assessment and share this with the rest of the group. And they continue to show that this intervention is more beneficial than harmful. This is from one of their publications, essentially showing pre-intervention. So the intervention essentially was a safety bundle that included, as well as adding a tick for non-Hispanic Black, also next to the tick, including institutional racism, also doing a lot of work around increasing staff awareness of institutional racism and these disparities. So a very different approach from what we saw with NICE. This is a very tiny slide, which you can read in your own time, but essentially what it illustrates is different examples of how race correction can cause harm. Somebody mentioned the EGFR. The reason the UK took away race correction for EGFR is because there was evidence that by race correcting for EGFR, Black people in particular were less likely to be offered renal replacement treatment therapy in a timely manner. So your disease would have to be much worse as a Black person before you were scored to receive renal replacement therapy. The same thing applied to pulmonary function tests in the US, where race was used for race correction, evidence that, again, Black people would have to be more sick before they got that intervention, which is why, again, there's a lot of advocacy with regards to removing it. In my specialty, in the US, not in the UK, they commonly would use a race correction for the vaginal birth after cesarean section calculator, a way of calculating the odds or of a successful VBAC, as we call it. And unfortunately, with that race correction, what that meant was that Black and Latino women were less likely to be offered or supported in having successful VBACs. And what that means is you increase your rates of cesarean section in this group, and also the cumulative medical complications that go along with that as well. Just to name a couple examples. So again, to remind us, these are eight useful questions, I think, if you want to introduce race in whatever risk-reducing interventions that are good to have and keep you, I guess, humble. So I think examples, I'd like to pause at this point and encourage us to think about these three examples. And I've picked these three examples because they're tricky ones. Continuity of care for racially minoritized pregnant people and women. So we know that continuity of care is evidence-based in that it improves outcomes for women and their babies and pregnant people. We know a supportive carer can mean people feel more advocated and safer in systems. So in England, they are advocating by, I think, 2035 or so, I'm not sure, that 75% of racially and ethnic minoritized women have continuity of care. We currently have in our screening pathway for diabetes that if you are a person of Asian heritage, that is considered a risk factor, and that triggers a screen at a lower threshold. And in England as well, there has been discourse around lowering the age of breast cancer screening for Black women because of evidence of not higher rates, but higher levels of more advanced disease at first presentation. So I'd like to pause here and maybe encourage us to, as a group, to think about what do we think about these three examples when it comes to race assessment. So let me see if I could close. I'm just going to shut my window down and see if I can encourage any feedback based on those principles about what we think is appropriate in these three settings. So maybe we can think of continuity of care. I'm just curious what people think about continuity of care using those kinds of principles. Or can we pop the examples in chat? Yes. Put them in the chat. So Here it is. So the 3 examples in the chat are here. And then I will also in the chat put the 8 questions to ask ourselves with regards to whether this risk assessment is appropriate. Just so I hear your voices, because at this point, I'm sure you're tired of hearing my voice. Oh, we've got a hand up. Is Lindsay? Hi, Lindsay.
Hi there. Thanks very much. That was really fascinating and shocking in some ways as well. I was just looking for clarification on what you meant by continuity of care. Just thinking
Yes,
of
sorry.
some of those outcomes that you were discussing around the interventions that are put in place for pregnant women, and obviously some of those could have both physical and emotional impact sort of once the baby's born, etc. And it was just to see where this continuity of care led to, and if that did include the opportunity to have things like birth reflections, meetings, or like wider support.
Yeah. Thank you for that question, actually, because I made that mistake of just assuming everybody knows. Sorry, that's bad of me. So and your question is even expansive, Lindsay, because on a very basic level, I would define continuity of care. Often they say primary care, of in a maternity setting, I guess, of having, either the same midwife or the same group of midwives looking after you during your pregnancy. Now, the question is, does that continuity of care, does it translate into the birthing period when you're having your baby and also after you've had your baby? Of course, it depends. At the moment, I'm not aware of anywhere where it's being done, but it's being, I guess, spoken about as a potential positive intervention. And what your question has also triggered in my mind is it's continuity of what kind of carer. So if we are saying the people that we wanting to support are the racially minoritized people, if you have the same carer who is not versed in cultural safety or issues around anti-racism, could that be more harmful than good? So so in this really small feedback session, it's not to decide whether or not we think race should be included in any of these 3 contexts, but it's just to talk about things we need expansion on and clarification on. So thank you for your question, Lindsay, because I think it's very relevant.
Thank you.
Hi, Andrea.
Thank you so much. Firstly, just a quick note, Avril, if you were able to stop the recording at this point, just so that people will feel more able to put the cameras on
Good shout.
and